this way a little bit then. So today I have, surprise, surprise, a total ear canal ablation to do in a dog that has an ear canal tumor. And so we're going to do a routine total ear canal ablation, but it's quite exciting today because it's the first time I've streamed on both of my channels at the same time. So I've purchased a subscription to a service called YOLOcast that allows me to stream to up to 10 different channels at the same time. So that's kind of exciting. So you can watch on either VetDojo or on VetAlign, but I prefer if you watch on VetAlign because I'm trying to transfer everybody over to my new channel. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. Now, Cassie, I'm going to have you push that scissor down and pull the ear canal up so that I can palpate. Just kind of lift it up a little bit so I can palpate where that ear canal is. Right there. So that's where the transition from the vertical to the horizontal ear canal is sitting right there. So go ahead and make my vertical incision right over that ear canal. And start our dissection through, and we really don't have a choice when we do this surgery in the way that I do it, but to go through the parotid salivary gland, which doesn't really cause a problem. I know that some people just make the incision around the external ear canal and then tunnel down, but I find it very challenging to see the anatomy that I need to see when I do that, so I feel a lot more comfortable by doing that vertical incision over the ear canal as the procedure is described in most textbooks. So just using my electric cautery to come down. I haven't seen... Yeah? Yeah. So coming through parotid salivary gland now. They even make a YOLO live box like the one that I use, but they have one now that is what is it called, Ultra HD, which is at 240p, or sorry, 2160p instead of 1080p, which I don't know how much that machine costs, but I'll have a look.
So we've just got a question here. Are we using gas anesthesia?
So we are using gas anesthesia. We're using isoflurane. What we've done is a pre-med with ACE and methadone. And we have induced with propofol. And then we're maintaining with isoflurane. And also, we've got it on a fentanyl CRI for pain relief. All right, so that's my vertical canal sitting there. Now we can take out that scissor. And I start making my circumferential incision around the opening of the ear canal. I did my first laser staphylectomy yesterday for a brachycephalic dog, and I have to say that it went very well. We've got a CO2 laser here that I had just never used. The dermatologists use it primarily. But that's definitely the way that I'm going to go, just for the advantages of decreased pain and swelling. I called those owners. That dog went home right after surgery. I called those owners and they said that he's doing very, very well, breathing really well. We're breathing up a little bit here.
Yeah, we just gave a little something.
Okay. Just give me a bit more propofol.
Yeah.
Blood pressure's good?
Yeah.
Okay. I'm continuing that incision around the back here, and then they talk about using laser for total ear canal ablations, for for decreased pain and swelling. I have not tried that. Still not totally convinced that I'll get the hemostasis that I need, but it's something I would consider doing in the future. So going through the cartilage here, taking out that antihelix.
Charles, do you care if we put this dog on the ventilator?
I don't mind.
Thank you.
So our nurses are just asking if we can put this dog on the ventilator because he's not quite ventilating enough. The reason you're doing that, is that just to keep the anesthetic, or
Yeah, it's just hyperventilating a little bit.
hyper?
Yeah.
Okay.
So you just go a little bit to the left, and then it does tend to pulse some bit 2 breaths below.
So I might get a towel clamp, and that really helps me retract. And because it's coming out with that ear canal, as in the ear canal is coming out, I'm not worried about doing trauma.
Is the tumor in the vertical canal or horizontal canal?
So good question. The tumor is in the horizontal canal near the tympanic membrane, so I don't think we'll ever actually see it. And the concern with a tumor in the ear canal is that it could be a serminous gland adenocarcinoma, which has a median survival time of only about 18 months if you do anything less than a TICA, whereas if you do a TICA, get a median survival time of about 4 years. They were not able to sample the mass. So worst case scenario, I don't think it is because it didn't look like it on the photographs, but worst case scenario would be a squamous cell carcinoma, which is much more invasive than serminous gland adenocarcinoma in dog ears.
And we have another question asking what your criteria is to tell the owners to opt for surgery.
So the reason to do a total ear canal ablation, it is a salvage procedure, which means that we're basically getting rid of the whole ear canal, so the dog will not be able to hear out of that ear. So it's either you have an anatomical reason why you can't get adequate drainage, like atresia or stenosis or a tumor, or you just have otitis externa that is refractory to medical management, or if you have otitis media that we don't think we're going to be able to resolve. So it's uncommon for an eardrum to be able to regenerate. So we've got a ruptured eardrum, that would be, if you had a ruptured eardrum, again with, really severe exudate going on inside the ear, then that would be an indication as well.
That one doesn't clamp well.
Thank you.
Another question, is there any calcification of the ear canal, or is the TICA primarily for the tumor?
So there's no calcification of the ear canal. There is this tumor, and then we are not able to medicate the ear adequately, so we have basically refractory otitis externa that we've been trying to medicate for a long time without success. And then we've got the fact that we've got the tumor, which is probably going hand in hand, although this dog does have some otitis on the other side and a yeast infection. It's not as bad as this side. All right, so and we're still breathing up against the Millie, we're still breathing up against the ventilator.
Yeah.
We might try to turn up the anesthetic just a little bit.
So just put your fentanyl on. Yeah, that's fine. Just you can go to 8. Okay.
So we're still bucking the ventilator here a little bit.
2 more questions. Is
Yep.
the canal going for histopath?
Yes, so good question. The canal is definitely going for histopathology.
And what's your favorite post-op pain protocol for these types of painful operations?
So I keep them on question is what kind of post-op pain medication do we use for these painful operations? Usually we'll keep them on a fentanyl CRI. If that's not enough, we might add a ketamine and or lignocaine CRI, depending on what the type of surgery is. I like to use lignocaine a lot for abdominal surgeries because it's a prokinetic as well. We can also use, I think we use a DOM CRI as well on these guys sometimes. So as I get closer to, and then we'll send it home incidentally, we'll send it home on a fentanyl CRI and probably an anti-inflammatory and probably some paracetamol as well. And if we need to, we can even add gabapentin. So as I get further down on the vertical canal, I need to make sure that I'm dissecting right up against the cartilage of the ear canal in order to avoid getting that facial nerve. And the facial nerve is going to be caudal, coming out of the stylomastoid foramen. So I have a little bit of bleeding. Not sure where that's coming from. So the facial nerve is going to be coming out here caudally, right where I'm working, a little bit deeper. Okay, so there's a branch of the facial nerve right there. So it's nice to see that because then I'm going to be able to trace that down to the main trunk of the facial nerve. So I don't think you guys will be able to see it. Cassidy, you can see that little branch right there?
Yep.
So this is the area where I have to be particularly careful.
Mm-hmm.
And I can sacrifice that little branch of the facial nerve because that's coming out with the ear canal anyway.
We have a request to be shown the facial nerve if possible.
Yeah, so the facial nerve is right here, but you won't be able to see it until I get the ear canal out of the way.
And another question, is there any risk of damaging the internal carotid artery? And what if this does happen?
So the internal carotid artery, I have hit it a couple of times before, and you get really significant bleeding. Basically, if you can hemostat it off, that's great. If you can't, then you just pack it off. And I have even had cases where I pack them off overnight and come back in the next day and remove the packing. Called a second look procedure, and we as veterinarians are very reluctant to do second look anything. We think we have to accomplish everything in the first procedure, whereas in human medicine, second look procedures are kind of standard operating procedure. And it certainly can get you out of trouble by packing things off and then just waiting, coming back in the next day. I've done that in abdomens as well.
Is there anything specific that you should pack with that's safe to
I
leave
just
in?
use lap sponges and then just pack it off, come back in the next day. Because you can leave anything sterile in the abdomen for 24 hours without any problem. retract that distally, please. Got a little bit of a bleeder right up here. I just have to be careful where I position my Gelpie retractors because I don't want to tether the facial nerve
You're
too
about
much.
to drop your freer by your hips.
Thank you. My field of view while I'm wearing loops is about 5 centimeters, so if I miss something that's happening off the that's out of my field, that's why.
So somebody's just asking about packing instead of ligating your large.
Yeah, so if you can ligate it, you're obviously better off, but the problem is that sometimes it's just bleeding so much that you actually lose a substantial amount of blood while you're trying to ligate it. And so in that situation, you're better off just giving up, packing it off, and coming back the next day.
And Ryan has asked what the source of bleeding was in the abdominal surgery you did that needed to be.
So that was so the question is, what was the source of the bleeding in the abdominal surgery that I had to pack off? And that was a liver lobectomy that I had stapled it off, but there was still bleeding coming through the staples, and I couldn't identify the source. So now I'm transecting the ear canal, and this is the point at which you can potentially damage the facial nerve. And I have isolated the facial nerve, it's right there, but I'll try to show it to you. Okay, so I found the tumor. I'll try to show that to you as well. Let's just discharge. Can I get suction turned on, please? And I'll have a normal freer elevator, please, to start with.
I don't think we have a suction tip either.
Can I get a freer elevator, please? Thank you.
And
Sorry,
we need a suction.
Fraser.
Suction?
Yeah. So that's the tumor sitting there. I'll try to get some more of it out.
You've been asked if you would worry about if you would worry about the packing not stopping the bleeding.
Question is, would I worry about the packing not stopping the bleeding? That certainly is a possibility, but sometimes you just don't have a choice. Can I get this put straight in formalin, please? This is a nice goopy bulla. So I'm just taking out the edge. And then the next thing I do after I've kind of cleared away the opening of the bulla is I'm going to come in ventrally with a freer and try to expose that a little bit more.
On that, he's been asked if this is a dental freer that you're blunt dissecting with.
I'm not sure if it is or not. It's just a standard freer that I use. So I do have a little bit of bleeding in here. So I'll pack it off for a minute. Can I please get some gel foam? Yeah, about a 2 by 2 square. So I've got this collagen, purified bovine collagen sponge, which is so good. Can you just pull on the pinna, please? Just a little bit closer, yeah. Reposition my guilty a little bit.
Charles, can I just ask you a question about the little boy I saw yesterday?
Yes?
So the owner just said he just hasn't wanted to drink anything overnight.
Yep.
So what would you like me to tell him?
Just try, if he's eating,
Yep.
maybe try to get some baby food
Yep.
and mix it with water.
Yep. All right.
You've been asked for the best piece of surgical advice for a fourth year to starting clinical rotations. It's relevant.
Give me just a minute.
Yep.
I'm kind of in an important part of the procedure right now, and then I will get to your question. I guess the main advice I would give is that we always say you can train a monkey to do surgery. So the technical part of it is not the most important part. The most important part is perioperative care, preoperative decision making, post-operative pain relief, and just being very, very complete and proactive with all of your decision, with your patient care and decision making and stuff like that. Can you get another piece of gel foam? Thank you.
Bring this over here for you.
I'm getting a moderate amount of bleeding here, so what I'm going to do here is I'm going to pack it off for 5 minutes, and that'll give you guys an opportunity, since we're all just going to be sitting here waiting, to ask me some questions. So there's a question about if you can't get the whole tumor out, is there still benefit to do the surgery? And so yeah, there is. So basically what we're doing is we're debulking the tumor, and the cause of the clinical signs of this tumor are because you're obstructing or occluding the ear canal. Once you get rid of the ear canal, you'll eliminate the clinical signs associated with the tumor. And so there is still benefit in doing it. And what happens is that it might slowly grow back, but it's not causing any symptoms because of the lack of the ear canal. just packing that off. Leave it for 5 minutes. Can we get a 5-minute or 4-minute time now? This is the longest 5 minutes of a surgeon's life. Waiting for this to...
Panadol, post-op as
Yeah,
well.
yeah,
No NSAIDs.
yeah,
Happy to ice pack if tolerated.
yes. So just asking, our nurse, Rachel, is just asking for post-op protocol, which is going to be Panadol, ice packing. It's already on steroids, and so we're not going to put it on non-steroidals. Continue the FentCRI. We'll put on a fentanyl patch.
What's the steroid? It's
Pred, 2.5 milligrams every other day.
Yeah. If we need trazodone, happy to give it. If
Yes.
we need.
Yes. So happy to answer any other questions right now while we're waiting.
Did you answer the second half of the tumor question?
Chemotherapy. So chemotherapy is not indicated for serous gland adenocarcinoma, but radiation therapy is very effective for residual disease. So if you do have radiation available, that's great, but chemotherapy has not been shown to be of any benefit with these guys. So, yep, Ryan just asked that question again that I had forgotten to answer before. And time, what is it, about 2 minutes?
Oh, Charles, 2 minutes 18.
What's that?
2 minutes 18 seconds left.
Okay, 2 minutes, 18 seconds left. That was a bit early, wasn't it?
Yeah.
Palladia, again, I'm not aware of Palladia being helpful, although it being a carcinoma, Palladia seems to be helpful in those types of situations, so it would be something that you could consider. But I'm not aware of any studies that have evaluated its use in that setting. It is the longest 5 minutes. But you have to wait that full 5 minutes because that's what it takes to stimulate clotting and to try to make a platelet plug and a platelet and fibrin plug that's going to stop the bleeding. So if we go in prematurely, we're just going to break the clot off and it's going to start bleeding again, and then you have to wait all over. Yeah. 1 minute to go.
Yeah, for the one dose of antibiotics, and that's it? Or do you
Yeah, yeah. And we can culture the ear canal now if you want. That's the ear canal there. We can see that it's stenotic. I don't know if you guys can see that. Let's see. Yep. Yeah. I'll culture the inside of this. So if we get the culture at... While we wait.
30 seconds.
So if you have an immunosuppressive dose of steroids, you very well could and should be concerned about wound healing. This dog is just on a very low anti-inflammatory dose, so we are not particularly concerned about it.
Hold on.
All right.
Have
So,
you guys given antibiotics now?
yes, I am. All right, so now I'm just really carefully going to pull this out. Hopefully. It's definitely slowed down. It has not stopped completely, but what I'm going to do is not suction the area that was really bleeding. the noise. So we're about to get a really nice big plug of shmoo. The best is when you get the whole thing out in one piece, basically like a grape skin.
Sorry, this is gula that you're pulling out?
Sorry?
This is gula that you're pulling out?
So I'm pulling out lining of the bulla,
Okay.
and it is coming out basically in one big piece, which makes me very excited.
It's kind of satisfying.
So now I'm just looking into white, basically white glistening bulla. There's usually a little pocket up here rostally as well, which I'm getting out now. I've put in probably about 50 mils of saline just so we know. And I can still see a big pocket of pus and cholesteatoma debris up there. See, that is a huge nugget of crap. I'll switch over to my smaller Fraser suction tip. And I have to be careful to stay away from the dorsal recess to avoid getting vestibular signs. So I'm just really picking out the shmoo that's up there.
We have a question asking if you can leave the gel foam inside the tissue, if it's better to take it out if the bleeding stops.
So if the bleeding has stopped, it's better to take it out, but often, as soon as you take it out, it starts bleeding again, so I don't have any problem with leaving the gel foam in there if I have to. So it's always this little rostral bit, and that's the trick, or the problem is that the big blood vessel is also rostral, and so I can't really just rongeur that out. So I just have to do my best to blindly debride it. Sometimes people use a arthroscope to look up in there.
Do you think that would make a difference to yours?
I have used them before when I've had to go back in. So Cassie just asked if I would ever consider doing that in my patients. And the answer is I have used it mostly when I have to go back in. I've probably used it 2 or 3 times in that situation.
And was that to retrieve remnants?
Yeah,
Okay.
to retrieve. If you guys couldn't hear that, that was to retrieve remnants of lining. so that's the vestibular recess right up there. I'm just being very careful to delicately dissect the lining from that. And there's a big chunk of it. I have to be so careful not to stick my instrument all the way up into that recess. Come on out, little fella. There we go. Nice big chunk. I'm just trying to get a better look up here rostrally. Alright, we'll switch to our other suction tip. Let's do a great big flush. Get some bupivacaine, please. So I don't know if you guys can see that, but the facial nerve
Back your head up a little bit.
is just right there. And I had sacrificed that little branch of it. Okay. I'll take a needle first, please. Yeah, thank you. And I'll tear that, or tip the bottle over. Try not to stab you. That should be heaps.
Do you have tips for preserving major nerves during TICA? And what should they do when the ear canal has proliferated and the major nerves have become trapped?
So the big thing is knowing your anatomy and knowing where they should be. And then the other main thing is just making sure that you stay right on that auricular cartilage as you're dissecting, because the facial nerve is going to be right up against the ear canal. Can I please get some 2O PDS? And then recognizing that in some cases you may end up either permanently damaging or completely sacrificing the facial nerve, which in a non-brachycephalic dog is not the end of the world, because they do learn to blink with that retractor bulbi muscle. you. Did I lose it?
Any reason that you started the suture at the center instead of at the edge?
So because we've just got this deep tunnel, I usually do a purse string around the tunnel, avoiding the facial nerve, deep before I start suturing the more superficial layers. And the more superficial layers I close like a T, and so I start at the top of the T, and then I'm going to come back and suture the horizontal portion of the T in just a minute. So just do another deep sub-Q here, and then we will wrap it up in just a second. So now I'm doing the horizontal portion of the T, the sub-Q. So that's pretty much it. We just have intradermals from here or skins from here. So if you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. And also, if you can subscribe to VetAlign, so it's at YouTube at VetAlign, VETALIGN. We are transitioning to that new channel almost exclusively. So go ahead and wrap it up. You want to hit the red button, please, Rachel, in the middle.